I think we'll start the afternoon session so that we can get going. This afternoon we're going to concentrate a little less on surgical technique, because we've had quite a lot of surgical technique in the last 2 days. We spent the whole of yesterday afternoon on surgical technique. We spent most of this morning on surgical technique, and some of the lectures that we had yesterday morning were also on surgical technique. So what we're going to do this afternoon is have a little bit more on philosophy in terms of what you do when you have a problem with complications. We'll do a little bit of recognition of how to avoid complications, and then we're also going to do a little bit about research, because I think it's important for us as sinus surgeons to base what we do on evidence, and to have some evidence for the techniques and maneuvers that we do. So the research aspect that I'm going to talk on this afternoon is the research that we've done in the animal model, looking at how the nose heals after surgery. So we're going to go through a whole lot of experiments that we've done, looking at exactly what happens to the sinuses after we injure the sinuses, and how these sinuses heal. Because I don't think there's a lot of science involved in the healing of the nose to date, and we really need to try and get a handle on exactly what happens to the nose after it heals. And the other area that I wanted to look at in terms of research was fungal sinus disease. Now, fungal sinus disease is an area of great controversy at the moment. I do think it plays a role in a certain group of patients, and I'll show you the figures and the research that we've done in the area of fungal sinus disease. So we'll have a bit of a potpourri this afternoon in terms of a little bit of surgical technique, a little bit of philosophy, and a little bit of research before we break for the case management this afternoon. So the first talk on the complications, I have spent some time on indicating that you've really got to look at the CT scans before you operate, and looking at the CT scans allows you to recognize the patients who are potentially at risk of danger. So we're going to go into that this afternoon. We're going to look at the danger involving the orbit, anterethmoidal artery, optic nerve, skull base, and briefly we'll touch on the management of maybe one or two of those problems. So those of you who read Chinese will be able to read this. Now, I don't read Chinese, so I can't translate it for you. But when I worked in Hong Kong, this was in the newspaper. And this was a newspaper report of somebody had had sinus operation, and they injured the optic nerve during the sinus surgery. So it does happen. You do get complications in sinus surgery. Anterethmoidal artery, medial rectus injury, that can occur as well. With injury of the anterethmoidal artery, you can get retraction of proptosis. Orbital penetration with injury of the muscle occurs as well. So we really need to, because these injuries do occur, we need to try and work out how to recognize the patients who are at risk, identify those patients, and then try and prevent this from happening. Now, those of you who have been listening over the last 2 days will realize that the anterethmoidal artery should be able to be found on all patients, on all CT scans. And if you look at the CT scan, you should be able to identify the anterethmoidal artery. So those of you who can't identify the anterethmoidal artery on this scan need to ask me to re-explain it to you so that you understand it, and that you are able to find it on every single scan or series of scans that you look at. The key is to run your eye up the lamina papyracea. So run your eye up and down the lamina papyracea, and where you see there's a tenting of the lamina papyracea is where the anterethmoidal artery goes into the anterethmoidal artery canal. And you'll never see the whole canal, because the anterethmoidal artery runs at an angle of 45 degrees across the skull base. So you'll only see it cut in various parts. So with each sequential coronal scan, you'll see a part of the canal. You won't see the whole canal. But here you can see more of the canal than you would normally be able to see. And you can see that this canal is lying in a mesentery. And in the cadaver yesterday, we had a similar case with the anterethmoidal artery lying in a mesentery. So that if you do see a case like this, be careful of coming along the skull base with an instrument, because we do teach in some instances that you may want to find the skull base posteriorly and come forward in patients who've got severe and extensive disease. But you've got to be aware of the patients who've got an anteethmoidal artery exposed, that as you come forward along the skull base, you're going to come into the region of the anteethmoidal artery, and you might damage that anteethmoidal artery. If the anteethmoidal artery is actually on the skull base, then it's not in your surgical field. Then you can do whatever you need to do in the sinuses without significant concern or worry about that. So here's an anteethmoidal artery which is lying right up against the skull base. We can see it on the skull base. So it's not lying in a mesentery. So that one is not in the surgical field. So what do you do if you're coming along and you accidentally cut into the anteethmoidal artery and you've got this little spurter? You can see spurting in the anteethmoidal artery. Well, what you do is immediately you put some local anesthetic packs into that region and pack that region. And immediately lift the eyelid and inspect the eye and see if you're getting any proptosis, and see if you're getting any subconjunctival hemorrhage, and evaluate the eye immediately, because that gives you the baseline from which you're working. Because you wouldn't normally expect to see anything straight away, but at least you've evaluated the eye now immediately after the injury. You then go back inside the nose, remove your pack, and you'll see that the artery comes from the eye and then goes across onto the skull base. That's the normal direction of the artery. So the feeder is coming from the lateral aspect. Now, if you can distinctly and discreetly identify the lateral aspect of that branch that's injured, you can use the suction bipolar just to go up there and bipolar it. You will never bipolar the medial aspect. The medial aspect is too thin, and even that amount of tissue damage, which is fairly minimal with a bipolar, is enough to give you a CSF leak in addition to the anteethmoidal artery rupture. So you convert one complication into two serious complications. So you never bipolar the medial aspect. Never do any sort of unipolar, bipolar, because especially with unipolar, you will arc through the dura and you'll have a CSF leak and a ruptured anteethmoidal artery. Now, if you don't have a bipolar forceps, what you can do then is you can just pack that area with a bit of Surgicel, a bit of thrombin, and then if you want to, after that, you can use a little bit of bib gauze in that region and just firmly pack that region, just nice and firmly pack that area. And that's all you do. Then go back and evaluate the eye again. You need to re-evaluate the eye a number of occasions. If you find the eye is becoming proptosed and becoming tense, and there's a hematoma developing retroorbitally, then you need to do something. There's two things that you can do. One is you can do a lateral canthotomy, and to do lateral canthotomy is very easy. Now, I wish I had thought of this yesterday and I would have demonstrated it on the cadaver for you, because it's a very straightforward and easy procedure to do the lateral canthotomy. You can do lateral canthotomy, or you can do a decompression. Now, if you don't have endoscopic skills, if this is your second or your third endoscopic case, then you should do an external approach and do a decompression externally. If you do have endoscopic skills, then it's very straightforward and easy to go back and remove the medial wall of the orbit like I demonstrated in the cadaver yesterday, and just to incise the orbital periosteum and relieve the pressure. But if you're getting an increase in proptosis in the eye, you really need to do something about it on the table. Don't wait for the patient to wake up and the patient to tell you that they are going blind and losing their vision. So don't use unipolar. If it does, you can bilaterally bipolar it. If it's medial, pack, you can use a variation of Surgicel, Avitine, and bib to control that. So the other area where you can create complications is in patients who've had previous operations. So patients who've had previous sinus surgery will often leave you with altered anatomy, so that your landmarks are different. And I did explain to you yesterday that in these cases where you don't have normal anatomy, or in these cases where you've got such severe disease that you cannot make out the anatomy in a decent and logical way, the technique for doing the surgery is different. The technique is we go in and debulk the nasal polyps, because there's normally a lot of nasal polyps in the nose, and we go posteriorly and find the skull base anterior to the sphenoid, because the skull base in this region is normally very solid and relatively thick. It provides a solid barrier to your superior dissection, and also the skull base is flat. You've got no lateral wall of olfactory fossa, which is thin and is potentially can be injured quite significantly and very easily without much manipulation. So you go back and find the thick skull base, which is normally flat, posteriorly, and then work your way anteriorly along the skull base into the frontal recess. And these sort of patients are very beneficial. If you want to clear the frontal recess in these patients, it's very beneficial to use the mini Trefine. Now I wish I'd remembered to show you the mini Trefine on the cadaver yesterday. You see, we should have done this lecture yesterday, and then I could have remembered to show you these. The mini Trefine is very, very useful little kit, tool kit, which makes a tiny little puncture hole on the outside of the in the eyebrow, and allows you to Trefine the frontal sinus. And you can irrigate the frontal sinus with some saline-colored water, and then that'll give you the pathway, because what you want to see is the pathway. So if you can't see the pathway, you can then do the mini Trefine, and you can see where the pathway is, and then you can slide your suction curette up the pathway, and then you can clear that frontal ostium. So the techniques are different for patients who've had previous surgery, where there are no landmarks. Be wary of overconfidence. Be wary of saying, oh, this is easy, we're going to go in and this will take us 5 minutes. I always get slightly irritated to the patients, to the surgeons who equate speed with excellence. I don't think that the two are normally go together. And normally the surgeon who says he can do a FESS in 20 minutes is either one, a bullshitter, or two, is a bad surgeon. Because anybody who does surgery in the sinuses with any degree of precision and care will take significantly longer than that to do a decent operation. So I don't equate speed. Overconfidence, saying that you can do something in a short amount of time, is not amounting to good surgery. And you're not doing either yourself or your patient any benefit by being an overconfident surgeon. Excessive force, be very wary of any maneuver in the sinuses which requires you to apply a lot of force on the instrument. If you're ever applying a lot of force on the instrument, think twice. Because either you're not doing the right thing, you're in the wrong place, or you've made a mistake in terms of where you are, and that excessive force is going to result in a complication. Either your instrument slipping through the skull base, or into the orbit, or damaging something that shouldn't be damaged. So just be aware of using excessive force inside the nose and sinuses. So let's just go through a little video here. We have a registrar of mine, and this registrar is in his final year. He's been through his training. He's done all his training. He's passed his final exam. He's just finishing his time with us, so he's got a couple of months of time before he goes out as a fully qualified specialist. Now, I do an eye list once a month at a different hospital from the one that I'm based at. So this day I was off doing the eye list in a different hospital, and he was looking after the list in our hospital. And I said to him, select a case, because the registrars normally select the cases. Select a case which you feel capable and comfortable of doing, that you feel that you'll be okay with, and then put that on the list. Now, this is the case that he selected. Now, to me, there was a number of poor decisions that he made. One, this patient had previous surgery, and therefore the anatomy was altered. And he still thought that this case was okay for him to do. So what he did is he went into the nose. This is the right side of the nose, and he started the operation. So I've taught him well, as you can see. He's going to do the swing door technique for uncinectomy. Even though the patient's had previous surgery, you can see the middle turbinate's been amputated. The unsnit is still in place. So the operation the patient has had was a relatively poor operation, in the fact that the unsnit had been left alone, and that a posterior ostium had been made over here into the maxillary sinus. So he fractures that up, and then he will take away the residual unsnit process with the 45-degree through biter. We have a rule in the hospital: every single surgical case is videotaped. So every registrar's case videotaped. And then if there's any problem, we review the tapes after the surgery. But every operation is videotaped. So that's how we got this video of this particular case. So the patient then has his little bit of the residual unsnit processes taken away with the straight shot. So he's done the uncinectomy. Now he's now going to look at the natural ostium. And you'll see that there's the natural ostium. Now I would not normally do this. I would normally dissect the bone out. But there's the accessory ostium, which was made by the previous surgeon. So he's going to join the accessory ostium with the natural ostium, which is the right thing to do. And so he's doing quite well at the moment. He's doing a reasonably nice operation. He's clearing the natural ostium of the maxillary sinus. So he's done quite well. So now he's looking for the bulla ethmodalis. So he thinks he's now opening up the bulla ethmodalis. So he puts the straight shot on what he thinks is the bulla ethmodalis, and then starts to try and open the anterior face. But he hasn't followed the principles. He hasn't found the natural ostium. He hasn't fractured the wall like I've showed you that he needs to do. So he now still thinks he's on the bulla ethmodalis. Now those of you in the audience who have significant FESS experience will realize that he's not on the bulla ethmodalis. That he's actually on the orbital wall. This is the lamina papyracea that he's currently working on. So he's currently working with the lamina papyracea, and you can see he's not getting anywhere. He's starting to use more force. So he's making the second error. First error was overconfidence in patient selection. The second error, he puts down the scope and he walks over to the CT scan box. Yeah, this is just fortunate that it happened that way. You can see him looking at the scans now. Because he put down the endoscope so you could see him walk over. And he comes back after looking at the scans, and he puts it back straight in the same place he was before. And you can see he's now got orbital periosteum exposed. He's now going to go through the orbital periosteum with a straight shot into the orbit. There, he's now in the orbit. And you'll see that's fat going into that straight shot at the moment. So orbital fat, you can see there. He's now chewing on orbital fat. So that's all orbital fat coming in. So he's now doing an orbital decompression a way that he hasn't been taught. You can see all the fat going into the straight shot there. So he chops a bit more off, see? So now he goes and he pushes on the eye. A bit late, but now his heart is down in his boots, because he realizes for the last 3 minutes he's been chewing on orbital fat, and he's wondering whether the medial rectus has gone into that straight shot. Because there's nothing, you know that the straight shot, nothing it likes more than polyps or polyp tissue, but it loves orbital fat just as much as it loves polyps. So if you stick a straight shot into the orbit, I'll guarantee you that you'll get a significant injury as a consequence of that. This patient developed an orbital hematoma post-operatively. He called me, I came in, we did an orbital decompression, took away the whole medial orbital wall, and we did a decompression inside the orbital periosteum. Her proptosis receded. Her eye movements were normal. About 2 or 3 days afterwards, she initially had some degree of diplopia on lateral gaze. So we were a bit worried about the medial rectus. We did a CT scan and an MRI scan within the first 24 hours after the surgery, just to ensure that the muscles were intact, and we could show that they were intact, but there was fairly significant hemorrhage. And he was just jolly lucky. He was very lucky. The patient had no long-term side effects, but all I can say is he was lucky. So I think what we wanted to show is that there are a number of bad decisions that were made. One, he took a case which was probably outside his level of expertise. Number 2, he was overconfident. Number 3, he used excessive force when he shouldn't have. So he made a number of errors. The other area of risk is the posterior ethmoids. Now, the posterior ethmoids can be at risk in the patient who's got a low skull base. So you need to be able to identify patients who've got a low skull base, patients who've got a curved posterior fovea ethmodalis, and patients who have an Anode cell. Because these patients all potentially can get complications. So let's look at the low skull base first. On the left-hand side, we have a normal patient. On the right-hand side, well, this is my right-hand side. Your right-hand side, we've got a normal patient. On your left-hand side, we've got a patient who's got a low skull base. And you can see that the fovea ethmoidalis on this right-hand side comes off near the roof of the orbit. So it comes off near the roof of the orbit. The fovea ethmoidalis on this side comes nearly 50% of the way down before the fovea ethmoidalis comes off. And what this does is it shortens the vertical height of the ethmoid complex. So it makes that ethmoid complex very much shorter than the ethmoid complex on this side. And you can see in the posterior ethmoids, you've got a much flattened skull base, which is coming significantly down. This point is about halfway through that orbital apex, whereas normally the skull base is on the roof of the orbital apex. So we've got a significantly depressed skull base. And if you don't recognize that you've got a very much shortened vertical height of the posterior ethmoids, you can sometimes think that you're in over here, and you can see that you've hardly done any dissection because it's a narrow vertical height. And you think to yourself, well, it's a narrow vertical height, then there must be another cell. And you'll think to myself, well, maybe I'm in this area, and I've got a cell above me, and that I need to go through. And meanwhile, you're in this cell, and you've got that above you. And to go through is just going to be to damage the skull base and to create an injury to the intracranial cavity. Patients who've got a curved posterior fovea ethmoidalis, normally the posterior fovea ethmoidalis, where you've got the superior turbinate, so where the scans where you've got the superior turbinate, normally the skull base is flat. The skull base is flat, so that you can normally make a dissection in the posterior skull base with a flat skull base. But this patient's got a significantly curved skull base in the posterior skull base. And you've got to be careful if you're dissecting in a cell like that you don't come medially. So if you come medially in a curved posterior fovea ethmoidalis, you're going to get an injury. One of the registrars created a CSF leak in a patient like this. He thought that there was another cell medially. He was in a cell up here, and he thought there was another cell medially because his understanding was the posterior fovea ethmoidalis was always flat, so he could come back horizontally. And when he did, he came across and created a CSF leak. So the fallacies of the anode cell, we did go through this yesterday. It's not a lateral pneumatization. It's not best recognized on the axial, but on the coronal CT. It's a superior pneumatization over the sphenoid. So let's look at the question about where the sphenoid begins. So if you run through those series of scans, I'm sure you're all familiar now at the transition between the posterior ethmoids and the sphenoid. And you can see you're still in the posterior ethmoids here. You can still go all the way up to the skull base. But here you've got the solid posterior choana. So you're moving from here from posterior ethmoids to sphenoid. And if you follow this cell back, which is the posterior ethmoidal cell, you can see that that cell is going over the sphenoid, over the top of the sphenoid. So it's pneumatizing over the top of that sphenoid. And this is what we call a horizontal septation in the sphenoid. I mentioned to you that the key to recognizing an anode cell is a horizontal septation in the sphenoid. So as soon as you see a horizontal septation where you've got a solid posterior choana, it means you have an anode cell present on that scan. So if you look at this series of scans, we follow this back down, posterior ethmoids, starting to get posterior choana here. So follow this cell, posterior ethmoids, horizontal septation bilaterally. And if you look at the parasagittal scan, you can see that how you get the horizontal septation is the anterior face of the sphenoid comes up and then it rotates backwards like this. And when it rotates backwards like that, if you've got an axial scan that comes through like a coronal scan that comes through like that, if the coronal scan cuts the anterior face of the sphenoid, you're going to get a horizontal because you're going to get this cell and then the sphenoid below it. And that's going to, it's the superior pneumatization of this posterior ethmoid cell over the top of that sphenoid, which gives you the anode cell, visible in that scan over there. So if you look at this particular patient, there's the anode cell. This is the anode cell here, and this is the optic nerve, which is running on that surface of the anode cell. So this is that posterior ethmoidal cell with the optic nerve running in it. So that's the way to recognize an anode cell, is the horizontal septation in the sphenoid. Your landmarks for sphenoidotomy, we've been through this yesterday in the cadaver dissection and today. If you take off the lower third of the sphenoid, you will find the ostium directly behind that. So at the upper two-thirds junction, by removing that, will give you access to the sphenoid. But what happens in a patient who's had previous surgery where there's no superior turbinate? So in a patient who's got no superior turbinate, you need an alternative mechanism to find the sphenoid ostium, especially if it's not visible when you're approaching it. And if you take the standard straight shot blade, and I'm assuming that most of you will have straight shots, the front end of the straight shot blade is 4 millimeters in diameter, and it's nicely rounded and curved. So if you find, going through the posterior ethmoids, if you find the bony rim of the posterior choana, and you can find that just by palpating it. So if you palpate the bony rim of the posterior choana, if you then make an impression in the mucosa, because the mucosa, if you can't see the sphenoid ostium, the mucosa is often going to be edematous. And it's very easy to just push the straight shot forward and make a 4 millimeter impression on it. And if you make another 4 millimeter impression directly above that impression, and you make another 4 millimeter impression directly above that impression, that means that you've accurately measured 12 millimeters from the top of the bony posterior choana upwards. If you then assume that in most cases the sphenoid ostium are going to be between 12 and 15 millimeters from the back of the posterior choana, that puts you exactly in the place where you want to be to find the sphenoid ostium. And you can push an instrument through, and I'll demonstrate that, you can push an instrument through the anterior face of the sphenoid by doing that. So let's look at a case. Here we've got a patient who's got an anterethmoidal artery, which we can see here, visible. If we go into the posterior ethmoids, you can see the first scan that you can actually see the superior turbinate. Going further down, see the superior turbinate. You can see the superior meatus. We start to visualize that there are two cells, one bigger cell and one smaller cell. Oh, this one's been turned upside down. And as we follow that cell back, we're just starting to get the transition now between this posterior ethmoidal cell and the sphenoid. And we can see we can follow that cell back, and it goes from the posterior ethmoidal cell, and it goes over the top of a relatively small sphenoid sinus which has been depressed inferiorly. So if we go back, we can see that these two cells, and we do the reconstruction, middle turbinate over here, superior turbinate, the anterior face of the superior turbinate. This is the large anode cell with the smaller cell just sitting lateral to that. This is the sphenoid, and you can see that this cell is pneumatizing over the top of the sphenoid. So if we look at the videotape, this particular patient, this is the residual bulla ethmoidalis. So we open up the bulla ethmoidalis. As I said, if you do this correctly, the registrar had followed these instructions, he wouldn't have got into trouble on that laminar papiratio, because he would have identified the natural ostium of the bulla first and then fractured the anterior face, and he would have realized, and if he tried to do that in the previous patient, that bulla ethmoidalis was not there. So we're now stroking the horizontal portion of the ground lamella, identifying where this horizontal portion of the ground lamella turns in that region, where it turns to the vertical. So it turns to the vertical right at that region. So we go in at that junction of the horizontal and vertical ground lamella. We know that we're going to enter the superior meatus at this point. So we will enter the superior meatus. We will expose the superior meatus. You can see it's got polyps in the superior meatus. And once we've exposed this in a lateral direction, we'll look for the anterior end of the superior turbinate, which you can see here. So we've got the superior meatus exposed. We now know there's a large anode cell up here with the smaller cell sitting just lateral to that, so that we will expose this anode cell and then look into the sinuses and look for that second cell which is sitting laterally. So as we go in, we can see that anode cell with the optic nerve, which is visible, going all the way back over the top of the sphenoid. Now we'll just open up that other cell which is sitting a bit more laterally, and we'll clear the rest of the skull base. So we're clearing the skull base now and identifying the skull base. And once we've identified the skull base, we'll go back and then look at the ostium of the sphenoid. So just clearing the polyps out. So that's the posterior ethmoidal artery coming at the junction. This is the anode cell with the optic nerve running through the anode cell. You can see it here. Carotid artery over here. In the carotid artery and the optic nerve within the posterior ethmoidal cells. So we're not in the sphenoid yet because we haven't opened the sphenoid. And you can see how the orbital contents cone away. This is the natural ostium of the maxillary sinus, and it cones away in a triangular cone type pattern towards the orbital apex. So now we're going to take down the lower third of the superior turbinate and identify the opening of the sphenoid sinus. So taking away the sphenoids, the superior turbinate, we're looking for the natural ostium, and we can't see the natural ostium. We're palpating like we do, and that we can't feel anything. Nothing's going in. So we're starting to doubt ourselves. So we're going to one indentation, two indentations, three indentations, and we still come to the same area. So we've just checked that to make 100% sure that we're still in the right area. So we're still in the right area. So we know that we're in the right area, so we can push a blunt instrument through. You see a little bubble that popped out there? And so we know that we're in the region of the sphenoid sinus. We can push a blunt instrument through, and then we can open up the sphenoid sinus. So there's the anode cell, which is sitting above that sphenoid sinus, depressing the sphenoid sinus. And this would be the horizontal septation that you see within the sinus on the CT scan. So we're just taking down that septation between the sphenoid sinus and the anode cell. And then you'll see that there's a large polyp. There's a large polyp within that sphenoid sinus. You just trim that polyp away, and that'll clear the sphenoid sinus. So the key in identifying the anode cell is to look at the coronal scans, identify the transition between the posterior ethmoids and the sphenoid. With CSF leak closure, we went through this yesterday. You tie a knot in the top of the fat plug. The fat plug is the same diameter as the defect. Thread the suture down the length of the fat plug. Place the fat plug intracranially, support it, and then the fat plug becomes larger than the defect. Slide a free mucosal graft up the suture to cover that defect, and a little bit of Merigel after that. So in this patient who's got a spontaneous CSF leak on the right side through the cribiform plate, you can see that there's a prolapse of dura, and the patient is having fluorescent stained CSF which is coming through. So we've just measuring that defect to get the size of it. We've cleared the mucosa around the edges of the defect, so we've got a good visualization. We're harvesting a free mucosal graft from the other side of the nose. We've taken the fat from the ear, which you just gently introduced the fat, and the malleable probe is much better. You see, the problem with the ball probe, with the little ball on the end of it, is if you stick that through, when you pull it back, it tends to hook a bit of the fat and pull a bit of the fat out. So that's why we developed our probe without a ball on the end, so that for things like pushing fat into the intracranial cavity, you really don't pull the fat out. The other thing you need to notice is that you put a little bit of fat in at the same time. You don't put a lot of fat or push a lot of fat through at once. Pull back on the stitch now, supporting the graft, pull back on the stitch. You'll see you get a little bit of fat out there. We do a Valsalva maneuver to make sure that we've got 100% seal. Free mucosal graft with a bit of fibrin glue and a little bit of gel foam, and then we cut the stitch, and that's the end of the CSF leak closure. So, how do we avoid lawsuits? So, a little bit of philosophy now that we've developed or looked at how to avoid some of the complications. Fellow John Locke said, all men are liable to error. So, I'd like to suggest to you that there's no one in this room who's done significant amount of surgery who hasn't had a complication. So if we've all had complications, then none of us should be pointing fingers at our colleagues. Okay, because I tell you, the quickest way to get a complication is to comment negatively about someone else's complication, because it's very funny how those chickens come home to roost very quickly. So I'd like to advise all of you to think before you speak with regard to your colleagues' complications. The other thing I'd like to advise you is that serious complications invite lawsuits. There's no doubt of that. If you get a significant and serious complication, the likelihood of you getting a lawsuit is fairly high. But you can guarantee a lawsuit. if you have a lack of informed consent, or you have any unprofessional conduct, then you will guarantee that you will have a lawsuit. So while you can invite one, you can also guarantee one by your actions. And there's no reason in this day and age why all our patients shouldn't be properly informed. I don't think there's any excuse for lack of informed consent at the moment. We are all very aware of the medical legal ramifications of our surgery. We do, and everyone knows, that sinus surgery carries two major risks. One is to the brain, and the other is to the eye. And that you really should be informing your patients of both of those risks before you operate on them. So I don't think there's any reason for our patients to have lack of informed consent. The other is in unprofessional conduct. And I will dwell for a moment on unprofessional conduct. Let's just look at informed consent before we go to unprofessional conduct. How do you decide on what to tell your patient? Well, you need to consider, when you decide what to tell them, your own abilities. And if you audited your own results and you know that your CSF leak rate with your sinus surgery is 5%, then you should say to your patient, listen, the risk of you getting a CSF leak in my hands is 5%. It's irrelevant to the patient what the literature risk is. We know that the literature risk is 0.5%, but if your risk is 5%, that's what you should be telling the patients. Look at the patient's educational background. You'll find that the patient who is a very educated, informed person will often require more detailed informed consent than a patient who is not that educated. And you should tailor the patient's information that you give them according to their educational background. You should address the patient's anxiety level. You might have a patient who is not very educated but is highly anxious about the operation and doesn't really want to have the operation. Be very wary of persuading a patient to have the operation. I say to the patient, this is what you've got. We've tried the medical therapy. The medical therapy's failed. Your CT scan reveals you still have significant disease. We can offer you surgery with these risks. How would you like to go? How would you like to play it? That's what I say to the patient. And the patient will say to me, well, what do you think, doc? I said, well, I think it will be in your best interest to have surgery, but really the decision is yours. The surgery is not life-saving surgery in most instances. It's not surgery that needs to be done in any short period of time in most instances. So if you want to go away and think about it, if you want to get a second opinion, or if you want to delay the surgery until you feel more comfortable, that's fine. I'm just telling you what we can offer you for your condition. We can offer you surgery, and if you'd like me to do the surgery, these are the risks associated with it. But I'm not trying to persuade you or twist your arm to have the operation, because those are the patients that inevitably will go wrong, and those are the patients who will come back to haunt you, are the patients who are highly anxious and you try and persuade them to have surgery. And remember that the patients might not always comprehend what you're trying to tell them in terms of risks and percentages. The disinterested patient, you can be trying to explain the complications ad nauseum, and you can see the patient's got a completely blank look on their face and they're not taking in a single thing that you're telling them. We always use preoperative notes, and in fact the College of Surgeons in Australia has got an official handout which is beautiful with diagrams and everything else, and it's got a little tear-off sticker, and you tear off the sticker and you put it in the patient's notes to indicate that you've given the patient one of these informed consent sheets. It's a very nice little system. So information sheets are very useful. Surgeons in training, and we have a fair number of our complications actually occur, as you could see, from registrars who are undergoing training, and it's the supervising surgeon who still maintains ultimate responsibility. And it's often the surgeon who might not have had anything to do with the actual complication who will get sued at the end of the day. So be aware that your registrars should be operating within their abilities, but you still need to give them the training to make sure that they progress. So they should be supervised and they should have a graduated surgical exposure. So this is how we train them in Australia. We're really hard on them. We always tell them it was much worse in our day and they've got it easy. It's not always true, but we tell them anyway. So if you have a serious complication, what do? You should immediately, if it's an orbital complication, get an ophthalmologist to come and help you. If it's a significant intracranial complication, get a neurosurgeon to come help you. So get the appropriate specialist help. You need to manage it appropriately. There's hardly a complication that you'll get sued for if you've managed it properly. So if you've ruptured the anterethmoidal artery, the patient develops a hematoma, you do a lateral canthotomy and an orbital decompression, the patient retains the site because you've managed the complication appropriately. Even though you've done a lot of extra surgery which you never intended to do, the likelihood of you getting sued is minimal, is very, very small. The times that you get sued is if you have a complication and you don't manage it appropriately. So you have a patient who presents the next day with a swollen eye and diplopia, and you pat the patient on the back and said, it's a little bit of swelling after the surgery, you'll be fine. That's the patient that you're going to get sued from, because you've had a complication, but you haven't managed it appropriately. You haven't gone and examined that patient. You haven't gone and investigated why this patient has got postoperative diplopia, whether there's been an orbital muscle entrapment, whether there's been a significant infection or whatever the cause is. So those sort of patients, you need to admit them to the hospital, you need to do the appropriate radiological investigations, you need to consult the appropriate specialists and manage the patient appropriately. If you've done all that, the likelihood of you getting sued is very, very small. So it's not, you're not going to get sued for complications, but more from inappropriate management of them. Always make your notes detailed and never ever retrospectively alter the notes, because that you lose your credibility immediately in the eyes of the court if you do that. If you want to make a retrospective alteration, that's fine, but make a date and make a little note to say this is a retrospective alteration. Right above the alteration, retrospectively altered these notes on this date for this reason. Sign and date any retrospective alteration you might make, but don't make it without being signed in. The other thing is with the patient. If you have a complication, go to the patient and tell the patient what has happened. Don't go to the patient and say, well, you had a minor problem. Meanwhile, you've had a major problem. We've had a minor problem. It's all going to be okay. Because then you raise the patient's expectations that it's all going to be okay, and it might not be okay. So don't go and tell the patient that it's been a minor little problem. Meanwhile, you've rogered the optic nerve or something. Don't go and tell the patient it's a minor problem. If you've got a CSF leak, tell the patient you've had a major complication. We had a CSF leak. It was a major complication. We fixed it appropriately, and you should be fine, because we've got a really good seal. We've put a nice fat plug up there, and there's a good seal, and you shouldn't have any more problems. But it was a major complication. Emphasize the fact that it was a major complication managed well. Don't minimize it. Don't tell them not to worry. It'll come right in time. Pat them on the back, because that's when you're going to get into trouble. So don't let the patient feel abandoned. Be involved and support the patient through all phases of recovery. Be concerned, but don't be familiar. The professional relationship with the patient. He's not your friend. He's not your buddy that you go drinking in the evening. It's a professional relationship that you maintain. So no familiarity with the patient, but be concerned. I think it's important, if your patient has had a major complication, to personally arrange all specialist consultations and second opinions, all special investigations, all treatment, and if legal action is expected, contact your local insurance company. What can you expect if a colleague of yours examines a patient of yours that's had a complication? Or if you've sent a patient, and a patient comes in and the patient's had an orbital penetration that your colleague has done, what can your colleague expect of you to say to this patient? I think the first thing is you obviously need to examine and take a full history. But I think the most important thing is that you should not pass an opinion on the work that is done. The patient is not consulting you on the competence of the last doctor. That's not the reason the patient is consulting you. And even though he might be your biggest enemy, and you might think it's a lovely time to get the sword out and put it in his back, it's the worst thing that you can possibly do. Because if you do that, and if you have a complication, you can guarantee that the sword will be out for you when your turn comes, because everybody who operates gets complications. So don't go and get the sword out and put it into the patient because the patient's come. You don't know. If the patient's had an orbital penetration, you don't know what is happening at the time. You weren't in the operating room. You didn't know that the anaesthetist was terrible, that the field was bloody and he couldn't see anything. He was doing the best he could. You've got no idea of the circumstances of what happened at the time of the complication. You were not there and you were not involved. So you should not pass an opinion on the complication. The worst thing that you can say to the patient is, you know, he's a bit of a shady doctor, he's a bit of a shaky Passing any opinion on the patient's, on the surgeon's abilities or credibilities or character is not what you've been consulted for. You've been consulted on the medical problem that's resulted from that complication. And if the patient asks you to comment on the surgeon or on what the surgeon's done, you say, I'm unable to comment. I was not there at the time. I do not know the circumstances of what happened. I can't comment. That's your... No negative comments, no innuendos about the treatment. I know it's tempting, especially if he's not a friend of yours, but really it's something that you very much should avoid. So treat the colleague as you'd like to be treated. Ask the patient if you can contact the surgeon and speak to the surgeon about the consultation. So if the patients come to you, say to the patient, do you mind if I phone your surgeon, the one that gave you the complication, and just discuss this with him? If the patient says, yes, I do mind, well then obviously you can't. Give or expect concerned criticism and honest and direct answers. I mean, if you've had a complication and you've done something which is inappropriate, then you should expect that your colleague would be honest with you and tell you about it. Remember that the patient has a right to seek legal advice, to inquire from the medical counsel as to your conduct, and a hearing by the medical counsel, and the patient has a right to pursue legal action. That's the patient's right. So the most common causes of litigation are failure to communicate a bad result. To say to the patient, you'll be okay, it is a minor problem. Very common cause. Failure to communicate a bad result. Resentment that the doctor was too busy to talk, to prevent it happening to other people, to obtain vengeance and possible money. That's an uncommon cause. Comments from colleagues and others. This is common. A lot of litigation started because of innuendo and comments from other colleagues. So if you get a significant complication, you'll note that it shakes your confidence. And that's why I said to you about the frontal recess. Go and start with the easy cases. Build your confidence up with the easy cases before you go to the more difficult cases. Don't go back after the course and start with a Kuhn type 4 cell. So if you have a significant complication, it shakes your confidence, influences you significantly and evaluates you. So take time and care. Don't be a fast surgeon. I would make it compulsory for a doctor using a brass plate to have inscribed on it, in addition to his qualifications, remember, I too am mortal. That's by George Bernard Shaw. Okay, any questions on... Let's have the lights up if we can. So any questions on complications, management, medico-legal aspects? I see a lot of expert witness cases. So a lot of my colleagues who've had complications, I get to testify for them in court. So I see a lot of the issues that were surrounding the particular case. I can remember one case that I'm currently involved in at the moment where the patient had a middle meatal antrostomy and the floor of the orbit was breached during the middle meatal antrostomy. And the patient was okay immediately after the operation. And then the next day had a little bit of post-operative diplopia. The patient was examined and had a CT scan done, and they showed that there was a tiny little bit of soft tissue coming through the floor of the orbit. Ophthalmologist was consulted, and ophthalmologist just suggested that the patient be treated conservatively. He went away, and 7 days later he sneezed, developed severe orbital emphysema and increasing diplopia, and then about 4 weeks after the operation still had significant diplopia, then was explored by the ophthalmologist, and they found that there was some fibrosis within the fibrous septae which surround the inferior rectus muscle, and the patient has retained significant diplopia after the surgery and has now sued the doctor. Now, to me, the only area of concern that I had with that whole case is that after the patient, everything I think was completely defensible, everything. Except after he'd done the surgery, what the surgeon did is he took a right angle curved sucker and he put some ointment, antibiotic ointment, on a 2 ml syringe and injected it through the middle meatal antrostomy. Now, I think if you've got orbital fat exposed, the paraffin that's in an ointment can give you a granulomatous reaction, specifically where you've got something like orbital fat exposed. And I think that that may well have contributed to the development of fibrosis in this particular patient. So if I had any criticism, it would be that act of injecting. I think the fact that the orbital floor was breached, that happens. That happens in surgery. It's not a problem. It's completely defensible if the patient had properly informed consent. Not a problem. The post-operative care of the patient, not a problem. Absolutely nothing wrong with it the whole way through. The only issue that I could identify in that whole case was the injection of the... if you're going to inject anything, you should be injecting creams, water-soluble creams, but never ever ointment into the sinuses. Any other points you want to raise, Shan?
You mentioned about bipolar diathermy always. Do you have any evidence that a unipolar is always harmful to the patient?
There's a question that Sham asked is bipolar versus unipolar. If you're using a unipolar, and I don't allow the registrars to use a unipolar at all at any time in the nose and sinuses. There's been a fairly large series of patients who've had unipolar specifically at the back of the middle turbinate in the region of the sphenopalatine artery. Now the region of the sphenopalatine artery is where the biggest vessels in the nose are. And what you'll find is that if you get a good sized bleeder there, you'll often find people will take a unipolar suction bipolar, a unipolar suction diathermy, and they'll take that suction diathermy and they'll put it in that region and they will stand on that thing. And that what happens is you get a crust, a black eschar that forms around the thing. And when you pull it away, you pull off the eschar and it bleeds again. So you keep on doing the diathermy. And I think in those cases where they've had, and they turn up the amount of the diathermy as well because they're not getting what they think is enough hemostasis. And there's been, I'm aware of about 7 cases of blindness after such a unipolar diathermy in the back of the nose. So what's happened is that the current has arced from that region. It's only about 12 millimeters to the optic nerve, and it's arced all the way up to the optic nerve and caused damage to the optic nerve. So that's with at the back of the nose. I know of at least 4 or 5 CSF leaks that have been caused by unipolar diathermy on the roof of the nose. So if you've got a little bit of exposed dura, if the current then arcs to that dura, it burns right the way through, and then you get the CSF that comes out with the current burning a hole in the dura. So I don't allow unipolar diathermy at all in the nose, just bipolar. Any other questions? Yes, sir.
Have you been fired by the court for your colleagues' case acting on expert to explain it?
Did I what?
Have you been invited by the court as an expert to explain your colleague's complication problem, maybe?
Now, you see, when I'm asked to give an expert witness, I'm asked to give an expert advice on his complication. In other words, whether, first of all, his pre-operative informed consent, and his informed consent was fine. There's not an issue with it. Whether the fact that he breached the orbit was negligence or not, and I said it's definitely not. And whether his post-operative care was appropriate, and definitely was. The comment I made about the paraffin gauze was something that I picked up from the notes, and it's not something I'm going to bring up in court. I don't know if the patient's lawyers are going to bring it up, but I'm not going to bring it up because it may or may not. I have no proof that the injection of that ointment had any relationship with the complication. So it would be speculation on my behalf that that was the case. So I'm fully defending this guy 100% and all his actions because I don't have any proof. But if I had any criticism, it was just with that action in the management of that patient, nothing else. Did that sort of answer your question? Any other questions? So we'll move on to the next presentation. Now, I think that one's taken a bit longer than we intended it to. John, when is tea time? 3 o'clock. Half an hour. Okay, we're not going to get through all 3 talks, so I want a show of hands. The 3 talks that we've got left are sphenopalatine artery ligation, and that's a fairly quick talk. And then we've got healing in the nose and fungus. So All of those for sphenopalatine artery ligation, raise your hands. Okay, all those for fungus. And all those for healing in the nose. Okay, so it looks like we'll do them in that order. And we'll finish at 3 o'clock. We won't go over time, John. How's that?